So one of the things that's pretty well known out there is older adults struggle to get acute illness care. And with patients with dementia, it's even harder for them, right? So you have symptoms develop, you feel ill, you call your primary care provider, and it's going to can potentially take a little while to get in to be seen, or you call your subspecialty provider, and it's going to take a little bit to get in to be seen. That, combined with the fact that they often have functional limitations, transportation limitations, results in us seeing them in the emergency department pretty regularly. We're happy to take care of them. I think we actually do the best job possible we can to take care of them. But when a person has dementia, the emergency environment's challenging, right? The noise, it's unfamiliar, it's disruptive. Even with the geriatric ED initiatives, food and water may not be readily available. And it just becomes really stressful, and who knows where that can go necessarily. So the question that we really started thinking of is, how can we provide emergency care to these individuals without that added stress, without that piece that necessarily just makes it a bad experience for them or makes it challenging for them and even their caregiver potentially. And so one thing that's been tossed around for a long time has been telemedicine. And as the technology's improved, what we had done a few years back is done a study in general with older adults is, can we use telemedicine to replace ED visits and even urgent care type visits? And we found 18% reduction in ED utilization when we did that study. The question that we started to ask just this last year was, well, what about people with dementia, right? They're even more vulnerable than your average older adult. Maybe it works really well for them, or maybe it doesn't. And to our pleasure, what we saw is that telemedicine, that our telemedicine program, when we gave it to these folks in the intervention group, reduced ED visits by 24% per year, which was really fantastic to see. Now, I think there's an important caveat to throw in here. So telemedicine, when the average person thinks of it, that maybe your insurance plan offers you, is basically video conferencing, right? So it's depends on what the back-end software is, but it's basically like FaceTime, and you talk to a provider on the other end, and that's what it is. What we do, and which is why we call this high-intensity telemedicine, is we actually sent a technician out to the patient's side. They would collect the information. They would collect pictures, sounds, belly sounds, heart sounds, lung sounds, pictures of eardrums, video of people doing things, and then they would link that up with the provider that's providing the telemedicine care, the physician or the advanced practice provider. So this had a much higher level of capability than what the average individual gets from most of the commercial services currently. And so there's a little difference that I think is an important caveat to understand, but we felt it was very important for folks that have multiple medical problems, that have multiple medications. This person can do a medication reconciliation, that may need some testing or something like that. And so we found it worked great. The challenge with this recent study, of course, is we're just analyzing data from a previous study, and so that is a limitation. Ideally, someone either needs to replicate this or think about whether this could have essentially be a false positive result. We personally don't think so. The signal is so strong and it makes so much sense to us that we think we found a real significant finding here. But you can't change the world with just reanalyzing other data out there necessarily. So the researcher in me kind of is a little bit cautious about this, but I think that it's fantastic and that changes the game, right? If you can just take care of people in their home, it's the easiest possible, it's a comfortable environment, you don't have to travel, and I think for folks with dementia, that can be a complete game changer than the environment that we put them in a hospital. So I think there's really two models in my mind there. One is to actually have the staff at the facility be that technician. We really explored that in the research study, and the partners we worked with actually cautioned us against that for a variety of reasons. But I think it could still work. I think it just needs to be in the right environment, and you need to figure out what's going to work in your community. The other model, which actually has a little bit more flexibility, is to have it almost be kind of like a utility model, right? So the utility company owns the power lines, but who generates the electricity and who actually uses the electricity can change. And the advantage in my mind, thinking very long term and thinking big, is why not be able to provide this type of service to people who live in their own homes? In that case, you're not going to have that nurse or nursing aide or someone like we have in these facilities. And so the advantage would be that if you have these folks independent, I mean, not to use a brand name, but Uber could be this provider, quite honestly. They could really go to these senior living communities. They could go to Jane Doe at her home and help her out there, or whatever the case might be. And even though I'm not involved with these, I know there are I've heard of a few companies out there advertising and whatnot that are exactly looking at this, and some health systems that are exactly looking at this as a way to really change how we deliver healthcare. Because if you think about it, right, so the current model of healthcare we have, of everyone coming to the doctor, coming to the hospital, we've gone to the moon since that model had come out. Why not change how we deliver healthcare so it's much more convenient, much easier, much less stressful? And I think that's where the potential is long term.